morning. Yes, Ms. Neal.
My lady, I believe there are questions for Professor Powers from some of our core participants.
Certainly. Who's going first? Mr. Drury. Oh, you're over there. Behind you, but if you could make sure your answers go into the microphone, please, Stephen.
Thank you, my lady. Morning, Professor. I ask questions on behalf of the Independent Ambulance Association. I have two areas to ask you about, please, and the first is this. And please make sure when you answer, I know it seems very unnatural, that you swivel back to speak into the recording device. Thank you. In your fourth witness statement to Module 3, you set out details of the 11 NHS ambulance trusts, their structure and their interrelationship with the Association of Ambulance Chief Executives. And you go on to set out NHS England's role in providing national leadership for the ambulance service. Now, despite the NHS investing in excess of £500 million a year in non-emergency patient transport services, and that this service could not operate without the assistance of the independent ambulance sector, which provides about 50% of the service. This activity is the only area involving such significant investment within NHS England that doesn't have a permanent national team providing oversight and leading or coordinating the work. So after that rather long introduction, my question is this. Do you agree that the creation of a permanent body or team within the NHS specifically addressing the challenges of providing non-emergency patient transport and issues such as consistency in approach across the trusts, the commissioning of services, innovation, equality of access, procurement and value for money would be both sensible and beneficial?
Thank you. Well, I think the honest answer is I neither agree nor disagree. It's not a topic that I've thought about in detail. I think the first thing to say is clearly we value the work of independent contractors in supporting the ambulance service and patient transport, and even more so during the pandemic when everybody pulled together to provide the additional support and resource that was required. As you will know from my statement and from the oral evidence of Anthony Marsh, who leads on our behalf at NHS England on ambulance service matters, the 11th ambulance services are independent statutory organisations. We do rely on them. They have their own individual systems and processes, although clearly there's a commonality in the overall approach they use. As I outlined in my previous evidence, we did, in a level 4 and a level 3 incident, go into much more direct command and control. Anthony Marsh explained that in his oral evidence. But I'm not sure whether in normal times, although as I say I agree nor disagree, whether setting up more permanent structures for that particular sector of ambulance services and patient transport, whether the benefits would outweigh the disbenefits, but certainly something worthy of consideration.
Thank you. Can I move on then to my second question, which concerns lessons learned and future guidance? And again, my focus is on the ambulance service. Last Thursday, Ms. Neal touched upon the question of who should be consulted, and you mentioned Anthony Marsh, who gave evidence previously to the inquiry, and mentioned the role of the independent ambulance sector. Can I ask you this, however, looking for your opinion? I know you say that perhaps you're not the person who should be asked this question, but given the specific challenges that you know of from your experience, because you have oversight of it in the ambulance sector, including the specific difficulties that paramedics and ambulance staff face. For example, they're the first to come into contact very often with patients. They have a lack of information. They work by definition, sometimes in very confined and constrained areas. Do you agree that it would be helpful within any future guidance regarding working practices to include specific and clear guidance for the ambulance sector addressing their unique challenges?
Well, in principle, I absolutely agree that whether we are dealing with core NHS organisations or those in the independent sector that are supporting us, and that I think is across a range of independent sector provision, including independent hospitals, that working in consultation is a principle that we would want to keep to, and working in partnership as much as possible. And so that does seem a sensible approach in normal times, and of course even more so in pandemics. But of course always recognising that as independent organisations, they will have a different set of constraints and a different set of aims, albeit that clearly in an emergency we all come together to essentially do the right thing.
Thank you, Professor. Thank you, my lady. Those
Thank
are
you,
my
Mr.
questions.
Roberts. Very grateful. Now I think we have Mr. Wagner, who's over there.
Good morning, Professor Powis. I act for 13 pregnancy, baby and parenting organisations. And I want to ask you about a single area, which is care for miscarriage and ectopic and molar pregnancies. You exhibit a graph in your fourth statement, paragraph 1185, and I'd like it to go on the screen, please. It's INQ 000485652 underscore 323. Thank you. So you can see there, it goes from January 2017 to May 2022, and it's inpatient episodes for miscarriages, ectopic or molar pregnancies or stillbirths. And obviously you can see there is a significant dip around, I think it begins in March, it's around March 2020. And in your statement, you describe the graph as showing a marked decline in inpatient admissions in respect of care for miscarriage and ectopic and molar pregnancies in March 2020. And the graph also shows that these numbers remained lower than the pre-COVID figures, or appeared to, well into 2022. And you say in your statement the dip likely reflects the preference of women to stay away from hospital settings and changes in the RCOG guidance on management of ectopic pregnancies. Now, in May 2023, the Miscarriage Association carried out a survey of women who experienced pregnancy loss between April 2020 and 4th of July 2021. And during that period, appreciate it's slightly, it's the second part of that period, 40% of women and pregnant people reported they were not able to receive their preferred management method for those miscarriages, ectopic and molar pregnancies. So my question is this, if you excuse the long introduction, do you agree that in addition to the possible factors that you mention in your statement, that marked decline in the inpatient admissions could also be reflected of the fact that many women were unable to access what they preferred to be their management method for their miscarriages and ectopic pregnancies?
Thank you. And we discussed this in general in my evidence in previous sessions. Clearly, particularly in the first wave, in March and April of 2020, we saw a reduction in people attending hospitals for a range of conditions. This is one set of conditions, but we saw similar dips in cardiac conditions, other conditions as well. And of course, that was, as I said earlier, very concerning. There are likely a number of reasons for it, as you have pointed out, and I've discussed around people not wanting to come into hospital because they were fearful of hospital, where infections might be higher, of trying to assist the NHS. We would have preferred them to come, but quite clearly some people felt that they should let the NHS get on and manage COVID, and other reasons too. And we talked about the Protect the NHS slogan and its potential impact. So I think there are multiple reasons. We did not stand down emergency and acute services, including maternity services during this period. But of course, there was a lot of disruption, particularly during wave one, where we were heading into an unknown pandemic in the alpha wave. The following winter, we obviously knew a lot more about the virus and how to manage it. So I think there are a range of reasons, but clearly this is something that was worrying at the time. I spoke about it early in generality about the need to come to hospital or need to come to appointments, and it's certainly a lesson for future pandemics that we should watch out for this and ensure that the public messaging is supporting people coming to hospital or to healthcare settings.
Thank you. And the second question, a shorter one, is you refer in your statement to the all-party parliamentary group on baby loss, calling in August 2024 swift reinstatement of the provision of choice for women facing pregnancy or baby loss in all trusts, including treatment options and interventions and options after bereavement to make memories or spend time with their babies. Were any steps taken by NHSE to comply with that recommendation at the time?
Well, we tried. Our intention was to get services re-established as soon as possible, particularly after wave one. As I said earlier, in wave two, although services were disrupted, we did not stand down services to the same extent. Of course, again, these were services that were not stood down. And so the intention was to try and get back to as near as normal as possible, as quickly as possible. But clearly we were still in a pandemic. Clearly there were still infection risks. Clearly we had visitor guidance and other policies in place to protect patients, staff and the public. So as I know we have discussed in previous evidence, this is one of those tricky balances which requires judgment. Will not necessarily be the same judgment in one part of the country compared to another. State is different. Underlying community prevalence is different. But the principle is to try and get back to as near normal as possible, as quickly as possible, albeit with those constraints.
Thank you.
Thank you, Mr. Wagner. Mr. Wolfe, I think, is behind the pillar.
Good morning, Professor Powers.
Good morning.
I ask questions on behalf of John's campaign, the Patients Association and Care Rights UK, all of whom represent people drawing on the health and social care and their families. My first question is about patient participation and consultation. Paragraph 53 of your witness statement, you talk about the way in which NHS England had regular forums with the BMA, the Royal Colleges and medical providers. Can I just ask you about that? To what extent did consultation with patients and potentially their families feed into those conversations with the BMA and others?
The consultations of the BMA and the Royal Colleges, I think I discussed in the statement. I need to look at the paragraph 53. I think of my third witness statement, correct? Perhaps not, perhaps it's the fourth. But those conversations were mainly professional conversations that I had around informing the colleges of the BMA, things that we were doing at NHS England, but similarly hearing from them concerns that they had. So they were not specifically designed to involve patients and the public, although some of the, many of the organisations on that, of course, do have processes by which they themselves liaise with patients and public and are very strong advocates. There are other mechanisms by which we gather information and consult with patient groups and the public. There are many organisations that advocate on their behalf. As I discussed in previous sessions of evidence, that became more challenging, particularly in the early part of the pandemic, when you do not have the time that you usually have to undergo that consultation. That is regrettable, but it is the nature of a fast-moving pandemic, particularly in the early stages, that there is a need to get guidance out quickly. So again, it's back to the theme of a difficult judgment, a balance of risks to take that changes over time. But the key principle is that as much as possible, we at NHS England would wish to consult with public and patient groups.
So my clients take the view that there might be some specific benefits from having a patient consultation focus included within those BMA and other dialogues. I mean, you don't disagree with that, do you?
I don't disagree in principle that it's important to have those contacts, and of course I would have other meetings with charities representing various patient groups. The particular meetings I was referring to were quite tight discussions around transfer of information, and so it might not be the most effective way of doing it. So in principle, no, I wouldn't object, but there may be better ways.
So my further questions are about visitor guidance, which you talked about to some extent on Thursday. Paragraph 240 of your witness statement, you recognise that it can be more difficult to provide compassionate one-to-one care and detect signs of deterioration in the condition of a patient when there are no family members around. And my clients would agree with that. To what extent was that taken into account in the evolving flexibility that was introduced into the visitor guidance?
Again, it was one of the reasons that we wanted to become more flexible on visitor guidance as quickly as possible. Again, a topic we discussed earlier, and again, one of those difficult balances in terms of protecting staff, patients and visitors from higher rates of infection, but at the same time providing that flexibility to allow people to visit. So if you look at the various iterations of the visitor guidance that came out from March and subsequently, there is a principle and a theme through all of them of trying to ensure that they were more flexible and then as rapidly as possible getting back towards where we were at the beginning, which was complete local flexibility around visitor guidance.
Any reason then why that type of situation couldn't have been introduced as a specific exception along with the others early on?
So I think we tried to put in as many exceptions as we could as early as possible, but clearly there is learning for future pandemics in terms of ensuring that we do that quickly and we extend that exceptionality as much as we possibly can.
So again, in terms of that evolving flexibility, to what extent was that flexibility not just about patients and families, but also about the reduced strain on staff and the benefits that that would bring for the NHS itself?
Yes, and I think you have heard that in some of the evidence that the inquiry has been presented with. Again, a balance, absolutely for many staff, the strain and the trauma of having to look after patients without the benefit of having close family and relatives to aid in that. It was really challenging, but at the same time, staff were really worried about spread of infection. They were really worried about catching COVID themselves and about people that they cared for who didn't have COVID, and of course, visitors and others catching COVID. So I think there was stress on, in both those areas. So staff felt a huge amount of stress about a lot of things, and one of those things that is difficult to reconcile. And I think, as one of the witnesses who's given evidence has said previously, it would have been almost impossible to come up with visitor guidance that would have satisfied everybody's concerns equally.
So final thought, in that involving flexibility, do you not think it would have been helpful to make the specific point that the local trust policies needed to look at the balance for the individual patient? This wasn't just a generic flexibility, it was about looking at risks and benefits for individual patients, whether a human rights focus or a public sector equality duty focus or simply an NHS good practice focus.
I think that was implicit in the guidance, but perhaps it might have been more explicit.
Thank you, Chair.
Thank you, Mr.
Thank you,
Wolf.
Professor
Mr. Stanton. Mr. Stanton's behind you.
Morning, Professor. I ask questions on behalf of the BMA. The first question I have is in the area of NHS Resilience. You refer to resilience challenges within your statement, including that these challenges not only affected the ability to respond to the pandemic, but also the ability to recover from it. And you made some recommendations within your evidence last week about the need for more capital investment and more staff. Can I ask you about another aspect of resilience, namely the extent to which the impacts of the pandemic on healthcare workers, such as burnout and long COVID, are a continuing barrier to the NHS recovery and therefore to its resilience?
Thank you very much. And yes, I absolutely agree that we have that ongoing impact of the pandemic and that our staff, even though it's now nearly 5 years since the start of the pandemic, there are still struggling and remembering the impact of those waves and the moral injury that we know they suffered, which is why, of course, we have continued to maintain a focus on health and well-being, why we continue to give as much support as possible and encourage local organisations who are at the front of this, at the front-facing part of this, to support their employers, and why, for instance, you will have seen an emphasis, to give one example, in resident doctors, doctors in training and other doctors to help employers do as much as possible to provide the support that means that they are feeling satisfied in their work, enjoying the work they do, because our staff are everything in the NHS. However much capital investment there is, however much infrastructure we put in, at the end of the day, this is a people service, and it's the staff of the service, as you quite rightly say, that make it what it is.
Thank you, Professor. Specifically in respect of long COVID in healthcare workers, you mentioned in your evidence last week that the turning point in your recognition of long COVID was in a meeting with Long COVID SOS on the 11th of September 2020. And you also stated that one of your earliest recollections of realising the impact of long COVID on NHS staff was the extent to which they were accessing long COVID clinics. Please can I ask you, at what point did you become aware that healthcare workers were experiencing a higher prevalence of long COVID than in the general population?
So I can't remember exactly, but it would have been pretty early on. And to an extent, it would not have been unexpected because we knew that healthcare workers were one of the groups that were experiencing a higher rate of infection per se, and therefore it would be logical that, unfortunately, they would also experience a higher rate of long COVID.
Thank you, Professor. And final question, still on the issue of workforce. You have indicated that even in circumstances where we are able to increase the number of staff within the NHS, there will always be a need for surge capacity to deal with a pandemic. And in this respect, the inquiry has been provided with evidence that has indicated that the full potential of the returners programme was not realised, despite the willingness of the staff, or the former staff. Please could I ask you, how do you think NHS England and individual trusts could have collaborated more effectively to have improved that potential resource?
Yes, this is one of the areas where I think we have reflected how we might have been able to provide more support for those returners, those individuals who had recently retired or left the health service for other reasons and who were willing to come back, might have been able to come back. And I think a lot of it is around the support for local organisations to streamline and undertake as efficiently as possible the sort of processes that you need to bring staff back in. And of course, this is at a time when they are trying to do a million other things because of the pressures of the pandemic. There are other lessons on this as well, but I think it's, to my mind, it is very much around how we can think about providing that extra support to make it as easy as possible for individuals to come back into the health service.
Thank you, Professor. Thank you, my lady.
Thank you, Mr. Sargent. Mr. Thomas, if you could take us up to marking Remembrance Day.
Good morning, Professor. My name's Leslie Thomas and I'm representing FEMHO, who are the Federation of Ethnic Minority Healthcare Organisations. And as you know, these workers faced unique challenges during the pandemic, and we aim to better understand the targeted support initiatives and protective measures implemented for them. So with that in mind, you don't need to turn it up, but at paragraph 709 of your witness statement, you highlight targeted initiatives to support Black, Asian and minority ethnic healthcare workers, acknowledging their disproportionate impact during the pandemic. Could you specify the types of initiatives that were put in place?
Yes, and we talked about some of these, I think, in the previous session. So clearly the risk assessment process that we put in place in the early phase of the first wave when these issues came to our attention was a really important process, and I outlined how by the time we had come to late June and early July, we were not satisfied with the progress that had been made, and therefore sought to provide as much support as possible to healthcare organisations to ensure that they undertook those assessments. And again, you will recall, and it's in the statement, heard also evidence from Dame Ruth May on this. We were particularly focused on supporting those trusts to undertake those risk assessments in individuals from ethnic groups that we knew were at high risk. And I think an exhibit was shown earlier in my evidence that showed that we saw a significant improvement over the following weeks, and particularly in individuals from BAME groups and other ethnic minorities. So that's one example. There's a range of other examples in the statement. There are examples around how, for instance, we supported Filipino nurses. I know Dame Ruth, in her statement, in her evidence, gave examples of how she had supported particular groups. And of course, when it came to things like vaccination policies later on, again, really targeted approaches, really a lot of effort going in to particularly support those individuals because, firstly, we knew that they had higher risk, and two, because it was really very high up on our agenda as a priority to provide that support.
Just in relation to those initiatives, was there prior engagement with Black, Asian, ethnic minority leaders before implementing them?
Yes, there was right from the start. So as soon as these issues came to our attention, and again, this is in the statement, the former Chief Executive of the NHS, Lord Stevens, called for a summit, which was held, I think, on the 15th of April, where healthcare leaders from ethnic minority groups and other groups came together as a starting point to discuss the issues that were being raised and to start to formulate a plan going forward. And I know my colleague, the Chief People Officer at NHS England, who led this work, spent a lot of time engaging with staff from those backgrounds, and of course the Race and Health Observatory was also established. I know the work had been ongoing prior to the pandemic, but that was another important point during the pandemic where we supported and put in place another bit of the system that would help support us in these efforts.
Mr. Thomas, I'm in your hands. I mean, I don't want your question or the answer to be interrupted.
Can I pause here?
If that is convenient for you, I think we'll all just pause until we get the indication that we should. For those who wish and can stand, we will stand in a moment.
For 2 minutes, silence will commence shortly with a single chime from Big Ben. Please join us and stand if you are able. Thank you. The silence is finished. And thank you for joining in our act of remembrance.
Thomas.
Professor Powis, we just looked at in the last question at what initiatives were taken given the disproportionate impact on black, Asian, minority ethnic. These initiatives, were they reviewed for their impact and effectiveness?
There were a number of evaluations undertaken of the programme of support we gave to staff. I indicated earlier that we'd be very happy to write to the inquiry with specific details over and above anything that is in the statement. But our principle is to evaluate wherever possible.
All right, well, if so, and I take it from your answer, you're saying that they were evaluated for their impact and the effectiveness. The follow-on question, and I want to be forward-facing, not just negative, what insights or lessons were gathered that could guide more effective support and strategies for ethnic minority healthcare workers in a future health crisis?
Well, I think there are many things that we are doing and can do. So if I just pick on one or two of the core things, I think we need our NHS leaders to be more representative of the staff that the NHS employs as a whole and of the communities they serve. We are making some progress on that. If you look at the percentage of individuals from BAME and other ethnic backgrounds who are in senior positions within the boards of NHS trusts, for example, that proportion is increasing. If you look further down, leadership in our organisations, particularly at Agenda for Change, higher band 8s and band 9s, we have not got the representation that we need, and of course those are the grades that are the precursors to moving up into the very senior leadership positions. We at NHS England are working hard to rectify that, to support people, to mentor people, to get into a position where they're in those senior roles, and I know many organisations across the NHS are doing something similar. That is one example. Another example I could give you is in our support for staff networks, in our work to combat racism, and again there has been a real focus on this recently, but I think, as you have heard, this needs to be constant and not just occurring when there are issues in the community that bring it to particular focus and attention. So there are many things that we are doing and many things that we can do, and I should emphasise it is of highest importance for us in NHS England that we address this.
Can I turn to my final area? Now I want to look at deployment decisions and risk factors. You see, it's been reported that Asian, black, minority ethnic healthcare workers were disproportionately assigned to high-risk areas during the pandemic, which elevated their risk of exposure to COVID. So question, did the DHSC's recognition of race and ethnicity as potential risk factors influence deployment decisions for these healthcare workers? Specifically, what measures were adopted to ensure that these workers were not placed at increased risk?
So, of course, the intent of the risk assessments that were undertaken was to identify those that were at the highest risk and working in the highest risk circumstances and, where appropriate, provide redeployment. That was the intent, that was the purpose of this exercise. And I'm sure that happened in many, many cases, but it may not have happened everywhere. This, of course, is a responsibility for local organisations with NHS England, NHS employees and others providing the guidance and the tools to do it. We did see in the staff survey, again, as I've mentioned, reporting from over the period October 2020 that in the round, staff felt their health and well-being was more supported compared to previous, although that dropped off again the year after. And I do think one of the lessons perhaps for us specifically is around in a future pandemic, understanding more the impact of those assessments at local level, as well as just whether they were undertaken.
Okay, well, that very nicely you bring me to my final question, which is this, and you've just touched upon it, and it's looking to the future. bearing in mind that you've just accepted that some areas or some of this impact may have been missed, what systems or protocols can have been established to prevent similar disproportionality in deployment assignments so that ethnic minority healthcare workers are adequately safeguarded during any future health emergency?
So I did just touch on that. So I think clearly ensuring that there is a risk assessment framework once we understand the nature of the risk that any future virus might cause. And of course, that is not always obvious at the start. But once that's understood, I think the lessons from this pandemic will set us in good stead for developing risk assessment processes and tools at speed. But I think in addition to ensuring that they are undertaken, doing more work around understanding their impact and the nature of that impact and where redeployment occurred and where it didn't, I think would be an important lesson for the future.
Thank you very much, Professor.
Thank you, Mr.
Millie.
Thomas. Mr. Burton. Mr. Burton's over there.
Thank you, my lady. Good morning, Professor. On the question of DNA CPRs, in its final report, the CQC concluded as follows. Every area we looked at had taken steps to make sure that services were aware of the importance of taking a person-centred approach to DNA CPR decisions and advanced care planning. However, we found that providers had to cope with a huge amount of guidance about all aspects of the pandemic that lacked clarity and changed rapidly, leading to confusion. I wondered if you agreed with that conclusion of the CQC, and perhaps more importantly, whether or not you could help the inquiry with any recommendations about how in the future NHS England could avoid or minimise confusion about issues as important as DNA CPRs.
So on the general matter of too much guidance or too little guidance, again, this is something that we discussed in the earlier part of my evidence, and I'm pretty sure I said that for every person who felt there was too much guidance, or maybe somebody else who feels that a specific bit of guidance was missing or should have been issued when it wasn't. And so this is a balance. It's a balance, again, that changes during the course of the pandemic. It changes according to the context. And in a sense, it's impossible to get it absolutely right. Clearly, guidance is required, not just from NHS England, but from other organisations, particularly in the phase of a pandemic, when evidence is fast-moving and gathering in its magnitude, quantity, and what it's telling us all the time. But clearly we are very conscious that having too much guidance can cause difficulties. It can be a distraction. It's a really difficult balance to maintain, and I think I said earlier that I think the most important thing is to be aware that that balance needs to be addressed rather than particularly trying to set it at one point or another. It's being aware of it and being as careful as possible to only issue guidance where it's absolutely necessary. On the matter of DNA CPRs, I think there were a lot of recommendations in the CQC report which were very helpful, and of course they have been acted upon. I think we need to be aware that this is a potential issue going into the next pandemic. There is clear guidance. There has been guidance over many years from professional organisations around the use of DNA CPR as one part of advanced care planning. It is not the same as advanced care planning. And I don't think that guidance necessarily needed to change, but we need to be aware that in times of emergency and stress, it may be used in a way that wasn't anticipated. And I think that's the lesson, to be aware of that going into the next pandemic, and therefore acting early to ensure that we remind people that the appropriate use of DNA CPRs and advanced care planning is the thing that needs to remain during the pandemic.
Thank you very much, Professor. I have some discrete questions about visitor guidance, if I may. You've explained how the guidance evolved over the first sort of 6 months of 2020 and in a more relaxed fashion. But you also came quite close to conceding in your evidence last week that perhaps the decision not to make allowances for people with learning disability and autism sooner was a mistake. My question is this. Did NHS England consult any disabled people's groups or otherwise carry out an equality impact assessment in relation to the visitors' guidance? And if the answer to that is no, the second question is, had it done so, do you think those mistakes might have been less likely to have been made?
I would need to write to the inquiry with the specific information on that. We did correct this, I think it was in the April guidance, so it was fairly soon into the pandemic. And as I said in previous evidence, this was in a sense new territory for us, in that visitor guidance had always been local guidance previously. So undoubtedly there are lessons to be learnt for next time in this area. And as I've said, the principle of consulting is something that we hold dear at NHS England, and it would be a principle that I think would serve us well in this area as in many other areas.
Thank you. And my final question is just about data. What steps are being taken in relation to improving data collection and dissemination across the NHS in relation to disability?
Again, something I would need to get back to you in writing over the specifics, but we are constantly trying to improve our data. I think the pandemic has taught us that there are some areas where we probably need more data, but again, back to the discussion that we had previously, we are very aware that putting too many data requests on organisations can have a disbenefit, but clearly in this area, I think it's important that we gather appropriate data wherever we can.
Thank you very much, Professor. My lady, that's the end of my questions.
Thank you, Mr. Burton. Ms. Alexis, who's just behind you.
Thank you, my lady. Professor, my name's Fallon Alexis, and I ask questions on behalf of the COVID-19 Alliance Against Airborne Transmission. CATA. My questions relate to the topic of PPE provision to healthcare workers, please, in light of the routes of transmission. And I'd like to ask you the questions, please, in relation to a letter that you co-signed with others. And can I ask, please, for document INQ 000130506 to be displayed on the screen, please, to assist you, Professor. This letter, as we can see from the first page, is dated the 28th of March of 2020, and if it assists, it's covered in your third witness statement, Professor, on page 109 at paragraph 386. And what we can see is it's sent, if we can just scroll down, please, just to the end, on page 3 and over to page 4, we can see, Professor, that it's signed by yourself there as the medical director, along with the medical director and director of health protection at Public Health England, and the chair of the Academy of Medical Royal College. And back up, if we can, please, just to set the scene. We are at the 28th of March of 2020, and this is a letter that you've sent to the chief executives of all NHS trusts and NHS Foundation trusts, the clinical commissioning group, accountable officers, GP practices, primary care networks, and providers of community care health services. And it provides a list there of who it was copied to, which obviously includes, as we can see, the Royal College presidents, the BMA, the RCN, NHS providers, along with others, including at the bottom there, NHS 111 providers. And thank you. And we can see in summary, I'm not going to go through all of it, but to help you with the question that follows, Professor, you set out at the beginning of that letter that you're grateful for the efforts of the NHS colleagues, and you hope that this letter clarifies your current approach and next steps in relation to NHS PPE. And if we could please, just looking down, we see that there are sections titled Supply, where you cover the supply, changes to the guidance, and then the current guidance. And my question, please, relates to page 3 of 5 of this document under the heading Comparison with WHO Guidelines. We can see in this section, Professor, you've set out what the UK recommends of FFP3 respirators when caring for patients in areas where high-risk aerosol generating procedures are being performed, and you've gone on there. And my question is this, Professor, if we read on, it says in the second paragraph, consistent with WHO guidelines, full sleeve gowns are recommended for high-risk procedures, e.g. during AGPs, or where there is a risk of extensive splashing of blood and or bodily fluids. In all other settings, the UK has a long-standing bare below the elbow policy as part of our long-standing strategy to manage healthcare-associated infections. COVID-19 is not airborne, it is droplet carried. We know the cross-contamination from gowns for infection can be carried by the gown sleeves, and the advice therefore is bare below the elbow, and you scrub your hands, your wrists and your forearms. Professor, please can you explain why you felt the need to so confidently and assertively rule out airborne transmission so early in the pandemic?
This letter was written in the context of the evidence that was available at the time and the IPC guidance at the time. As you pointed out in the letter, it points out that a further iteration of the IPC guidance was about to be undertaken. I believe that was covered in Professor Hopkins' evidence. So this is early in the pandemic and represents the position then. It was some time, of course, before the World Health Organization recognised COVID-19 as being airborne, and you have heard a lot of evidence around the method of spread, whether it's droplet, aerosol, and how far droplets or aerosols are carried and how long they stay in the atmosphere, in the air, and the surroundings to an individual. It's not an area in which I'm an expert. Others are much more knowledgeable about IPC and transmission and the mechanisms of transmission and the science of transmission than I am. But this represented what we knew at that time in late March.
I think we're going to have to leave it there, Ms. Fallon. I'm sorry.
Thank you, my lady.
Thank you. Ms. Stone. Stone's just there.
Good morning, Professor.
Good morning.
I ask questions on behalf of COVID bereaved Families for Justice UK, and I want to ask you some questions, if I may, all relating to NHS 111. Two areas, please. The first is triage and comorbidities, and the second is around meeting the needs of a diverse patient group. So in terms of the first of those, please, can I take you back to the HSIB report, which you discussed on Thursday in response to some questions? And that is the report about 111's response to callers with COVID-19 related symptoms during the pandemic. And Professor, you helpfully summarised the findings of that investigation report in your fourth statement. I don't think it needs to be called up, but for your benefit, it's at page 223 of that statement, should you need to go to it. But one of the findings that you set out there is this. The HSIB report found that the CRS COVID Response Service algorithm did not allow for assessment of callers' comorbidities to establish whether a clinical assessment would be beneficial. So it's that I wanted to ask you about. And by way of context, I think you said in your evidence, or at least it was implicit, that 111 operators wouldn't have access to medical records. Is that also correct? So firstly, as a matter of principle, for triage in respect of a respiratory infection like COVID, would it be important to assess a caller's comorbidities, to optimise the advice given, and in particular to consider whether a clinical assessment is needed?
So the evidence around comorbidities was evolving at the time when the service was initially stood up. We had a very robust process involving expert clinicians to consider any new evidence around the virus and its impact before that was operationalised into 111 CRS and other algorithms. That process did look at multiple conditions as soon as the evidence started to emerge, and then I think fairly rapidly did incorporate that in. So quite rightly, once the evidence was there, it was incorporated. Again, as you've heard, there were many changes made to those scripts and algorithms as the evidence emerged. But I think it is an important principle to ensure that you are confident in that evidence before you introduce it, because not in respect of multiple conditions, but if you introduce a change to the script which is not based on good evidence, then clearly there could be a disbenefit to that. So you do have to go through that robust process.
Understand that, Professor. I think the first starting point, though, is that I think it's implicit in your answer that it would be important ordinarily to consider comorbidities. Would that be right?
Well, I think it's important to introduce changes into those algorithms and scripts based on robust evidence. And I'm confident that there was a process in place to ensure that what was introduced had been looked at carefully and the evidence was felt to be strong enough to introduce it. So I think there is a difference between thinking at the start there is reason to think that comorbidities are going to be important versus getting strong enough evidence to say, yes, we are certain enough to include it in a set of scripts and algorithms. But I think in any event, that happened fairly rapidly early on. I think that was acknowledged in the HSIB report.
You've responded to some of those findings, including this one, in your statement, and you say in the statement that NHS England agrees that the system wasn't initially designed to take into account specific comorbidities due to limited knowledge of the virus, but you go on to say that there were lots of updates as the evidence base evolved, which I think touches on what you've just said. But I wanted to ask you this, in respect of that evidence base, please. We know that work was done early in the pandemic to identify particular groups who may be more clinically vulnerable to COVID for the purposes of developing the shielding programme. And by the 18th of March latest, there were lists of specific comorbidities which identified groups considered to be clinically vulnerable and clinically extremely vulnerable. So they had been identified by that date. Can I ask you this? Should that analysis have been translated across into NHS 11 triage and assessment protocols, such that callers should have been asked whether they had those specific comorbidities, thereby informing the advice that they received?
So I think you heard from the Chief Medical Officer, Professor Sir Chris Whitty, in his evidence that those initial comorbidities and conditions were derived from a set of first principles rather than necessarily an evidence base at that point. In other words, as we were just discussing, what you might reasonably expect rather than what you absolutely knew as per published evidence. And so I think that is a difficult balance. I think it's a perfectly legitimate question for you to pose and for us to think about for future pandemics. And clearly it is a balance between it comes back to the point I was making about how certain you need to be about the evidence, because if you include something before the evidence is certain, you also have to acknowledge that there might be a risk that might be a disbenefit. I think others who were more involved in the shielding programme than I would make the same point in principle around the shielding programme, that there is always a downside as well as an upside. So a perfectly reasonable question for us to consider, but not necessarily a straightforward one to answer.
Would you agree that in the context of a new respiratory infection that a precautionary approach would be important, and therefore that including these conditions that were thought from first principles, as you've just said, to have the potential for rendering individuals particularly vulnerable, that favours an inclusionary approach as far as 111 was concerned?
I prefer to think of benefit of risks, which again highlights the point I've made that there are always consequences to a decision, and you have to be really cognizant that sometimes those consequences can have a disbenefit or result in a harm to some individuals, even although you are trying to derive a benefit. So these are quite carefully nuanced decisions, and the principle that you should only make changes once you are as sure of the evidence as possible, I think would hold. But clearly, you, as was demonstrated in the shielding programme, you can start off with a set of possibilities that you think are the most likely things that you need to focus on. But I think, again, this is down to a balance of risks and a balance of judgment.
Another of the findings was that callers would only be transferred to a clinician or receive a clinical callback if they were, and I'm quoting, so ill that they've stopped doing all of their usual daily activities. Would you agree, Professor, that the imposition of such a high threshold for transfer to clinical advice was inappropriate in dealing with such a new and emerging infectious disease?
So again, this is a balance of risks, and again, a balance of what you can undertake operationally. In principle, we endeavour to put as much clinical support into our call services and into 111 as we can, recognising that in doing that, those clinicians are unable to do other things that we also might wish them to do. So again, we're into trade-offs. But in principle, we would want to try and set the appropriate threshold to get that clinical call initiated, because we also know, and we have discussed, that the call handlers are following algorithms, are not clinically trained, that getting that clinical input can be very important.
Turning to my second area, please, and that's the extent to which 111 was able to ensure it could meet the needs of a diverse population, particularly in the context it found itself. I want to ask you about three factors, please. The first being questions about lip and skin colour, the second being communication barriers, and the third being data. So the first area, please. We know from the HSEIB report that among the red flags for COVID was blue lips or face. I think you understand that, Professor, or perhaps knew it from your own knowledge. And from family members we represent, we understand that on occasion questions were asked of them about them or their loved ones, which assumed that they were white, for example, had their lips turned blue or their skin colour turned blue. Would you agree that there are dangers associated with that sort of standardised approach to questions about lip and skin colour without reference to the ethnicity of the caller?
So I think this is a general point which holds fast outside of a pandemic as well, and I think the medical profession and clinicians in general need to be more attuned to some of the phrases that we've used and some of the terminology that we have used over the years. That change is definitely occurring at the moment, but I would agree with you that we need to be cognizant of that.
And so would you agree that there should have been express provision, whether within the protocol and or the training of those call handlers, to ensure that a caller's ethnicity was taken into account when considering those sorts of clinical factors?
And I would say that in all settings, which are not just call settings, but in interactions that clinicians have on remote consultations, on a whole range of issues, we should be more cognizant that some of this terminology has arisen from white skin rather than darker skin, and it's inappropriate.
Language or communication difficulties, please, Professor. Another concern that was raised within the HSIB report was about communication with callers whose first language wasn't English. Would you agree that specific provisions should have been made for call handlers or operators to facilitate communication with those callers?
So as much as possible, I agree with the principle that we should have in place, and of course there may be operational limitations, particularly when you're standing something up at speed, around ensuring that we can handle as wide a range of language, accent and approach as possible.
Thank you, Mr. Ms. Hannett.
Professor Paris, I appear on behalf of the long COVID groups. I ask questions on two themes, data and communication. I could just ask you about data first of all. You acknowledged on Thursday that you're concerned about the variation in long COVID services. In addition to variation between the services themselves, the long COVID groups have raised concerns about issues in accessing those services across the board. Those include difficulties in obtaining a referral and long waiting times. The long COVID expert report indicates that 113,000 patients have been assessed by a specialist long COVID service and 125,000 referrals have been made by early 2024. By comparison, the ONS figures from March 2024 indicated that there are over 2 million people, including more than 55,000 children with long COVID. So it would appear that only a very small proportion of individuals with long COVID are accessing the care available. And indeed, Breitling and Evans, in their expert report to this inquiry, were concerned that this means that there is a big gap of people that aren't getting the support that they need. The ONS itself is no longer publishing data on long COVID. And would you agree, therefore, that NHS England would be assisted by national ongoing data collection on both the prevalence of long COVID in the population and data on the impact of its severity in order to allow the NHS to take a more accurate stocktake of need and to ensure that the right services are put in place to meet the demand?
Yes, and if I give some context, and again this is in my statement, we were very aware of the ONS work as we were developing long COVID services. In fact, the demand that we saw was less than we anticipated for the reasons that you said around that gap, although you are quite right that it still meant that there was waiting times for long COVID services, and as I touched on in my evidence in the previous session, there is variation around the country in terms of waiting times. Of course, you will see that in a variety of conditions. It's not just the case in long COVID, and in part it reflects the fact that these services are locally commissioned and the particular context and nuances of the local geographies and local configuration of services that integrated care boards now are working with. On the point of data, yes, I am somebody who believes that having more data is important and having a good understanding of prevalence and incidence of long COVID in the population, as it would for any condition, would aid us in commissioning. There are a number of ways in which that data can be established. It doesn't all have to be established by NHS England, nor either by the ONS, but in principle, yes, understanding the prevalence of a condition does aid us and our local commissioners in determining what services are required.
Thank you. I just turned into my next topic about communication. NHS England promoted a wide range of COVID-19 healthcare advice and guidance for the public, which have been developed by other organisations. And you give a number of examples of that in your witness statement, such as promoting a DHSC-launched public information campaign. The Department of Health and Social Care developed one video promoting public information on long COVID in October 2020. It's right, isn't it, that NHS England didn't promote that campaign or indeed publish any public information on long COVID via the NHS website?
I haven't got the details, but I've no reason to think that that's inaccurate.
Looking back now, then, in hindsight, do you agree that using available channels such as the NHS website to disseminate public information on long COVID would have helped individuals understand and identify what they were suffering from?
So, as you say, we did support a lot of communication around long COVID, and I think we do, through the NHS website, try and provide as much information as possible. getting that balance of how we provide enough information but not too much information is important, and it's certainly something that I think we should keep under consideration as these services develop and evolve.
And similarly, there's still no public health campaign informing of the risk of long COVID. Professors Breitling and Evans recommend that to improve access to long COVID clinical care, the first step is to improve the awareness of the general public around long COVID, and to enable people to recognise their ongoing symptoms and to encourage them to receive health care. Would you agree that there should be a public health campaign on long COVID so that sufferers aren't left to struggle without that information?
Well, I agree, like many other conditions, it's important that the public is aware of long COVID and symptoms. The way in which those campaigns work, and not all of them are undertaken by NHS England or indeed DHSC. There are campaigns from other groups as well in a range of conditions, not talking just about long COVID here. I think it's quite a complex matter, but in principle, I am in favour of doing as much as we possibly can to ensure that the public is well informed of a wide range of medical conditions, and I would include long COVID in that, because as you have outlined, there is clearly an ongoing need for long COVID services.
Thank you. Final question, if I may. And that's on the NHS communication on the symptomology of COVID-19. And until April 2022, NHS England's website continued to state that COVID was short, mild and flu-like, with only 3 cardinal symptoms of fever, cough and shortness of breath, despite a significant number of people suffering from other symptoms. The CDC in the United States, in contrast, was updating their website regularly alongside updates and understanding of new symptoms. Why did the NHS England not update its website information with updated understanding of COVID symptoms?
I can't give you a specific answer. I would need to write to the inquiry on that point, but in principle we do aim to update our websites to ensure that they are up to date with the evidence and contemporaneous, and of course you would expect me to agree that that would be a really important thing to do.
Thank you, Professor. Thank you, Lady.
Thank you, Ms. Hunt. Well, I think we'll break now. I think that completes the questions for you, Sir Stephen. Thank you very much indeed for your assistance. I'm not sure I'm going to thank you for whoever in your office produced such lengthy statements, but I promise to ensure that all material is taken into consideration, obviously the oral evidence and the written, but that file contains statements from you and Ms Pritchard, so you've given us quite a lot of material, and I do understand the burden we place on you.
And I hope they were useful.
Thank you very much for your help.
Thank you.
I shall return at 5:02.
All rise.
Ms Carey.
First witness, please, I'm going to call today is Miss Amanda Pritchard.
Please repeat after me. I swear by Almighty God.
I swear by Almighty God
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth and nothing but the truth.
The whole truth and nothing but the truth. Thank you.
Miss Pritchard, your full name, please.
Amanda Kate Pritchard.
I think you have in front of you 2 witness statements that you've made, both dated the 16th of January of this year, INQ 409250, which is 120 pages long, and 409-251, which is 353 pages long. I'm going to start with a little background to you, NHS England itself, and then delve into some of the detail dealing with the pandemic. May I start with you, please? Is it right that you joined the NHS Management Training Scheme in 1997 and have held a range of roles within the NHS since that date?
That is correct.
I think it's right that you have no clinical experience yourself. You were the Chief Executive Officer during the pandemic of NHS England, the Chief Executive Officer of NHS England since the 1st of August 2021, but prior to that date had been the Chief Operating Officer of NHS Improvement. Is that correct?
Yes, I've been Chief Executive Officer for NHS England and Improvement. It merged into a single organisation. That's exactly right, from August 21. prior to that, from 2019, from July 2019, I joined as Chief Operating Officer for NHS England and Chief Executive for NHS Improvement. They were working as one organisation at that time.
We've basically been using NHS England as a catch-all, albeit covering both NHS England and NHS Improvement, as then was. And I think prior indeed to your roles in NHS England and Improvement, you were the Chief Executive Officer of Guy's and St Thomas's NHS Foundation Trust from January 2016 to July 2019.
That's right.
All right. Can I ask you, please, at the outset, are you able to give us an overview of the size of the NHS in England as at around March 2020, in terms of budget, staffing numbers, numbers of hospitals, that kind of thing?
Yes, of course. And that is an important distinction between the NHS in England and NHS England. So the NHS in England at that time had a budget of about 1.248 billion, so 124 billion. Sorry, let me get that right. 124 billion. Yeah. We had 123 trusts, but that includes acute trust, ambulance trust, community mental health, 6,771 GP practices organised into about 1,250 primary care networks. The NHS operated at that time out of about 17,000 buildings, and overall we had about nearly 1.3 million staff employed in a range of different roles, as well as a whole number of staff employed through contractual arrangements to provide additional services for the NHS.
We are talking vast sums, a vast amount, no doubt, on your plate. Can I just ask you about this? The 17,000 buildings, they're not all hospitals, are they? That would include other premises that are required by the NHS to operate.
Yes, so a community trust might have literally hundreds of different buildings, ranging from small local services through to much bigger centres with beds in them. Equally, we've got GP practices I've already mentioned, but a whole number of other ambulance centres, etc., etc.
Understood. All right. Now that just gives us an indication of the scale of your job in running NHS England. And can I also ask to be put on screen, please, INQ 409-251_336. I just want to remind ourselves of some of the waves and the numbers of patients involved across our relevant period. And we can see there that during the first lockdown, the weekly patients in hospital are indicated by the blue line. So approaching in early 2020 up towards the 20,000 number of patients. If we just stick with the blue line again as we come to the second lockdown and into 2021, it goes up to nearly 35,000 patients and then drops down, and then various peaks and troughs as we go through 2021 into 2022. And you've helpfully indicated on there the weekly patients in mechanical ventilation beds is somewhere between 0 and 5,000, with a slightly less steep curves throughout the various waves. So on any view, significant pressures on the NHS in England around winter 20 into 2021. And we're going to look at some of those pressures in more detail. All right, that's just as an overview. Can I start, please, with your first witness statement ending 250? And I will try, Ms Pritchard, not to jump between the two statements, but it may be necessary at times. Is this the position that it's the Department of Health and Social Care that sets the strategy and the funding levels for NHS England? And it's NHS England that commissions the services, but does not make the political decisions. Is that correct?
That's correct.
It does not set the health policy.
That's correct.
And it does not provide patient services itself.
Yes, that's correct.
And it is the workforce of trusts that are not employed by NHS England, but by the trusts themselves.
Yes, that's exactly right.
And if we could just look at some of the numbers of trusts, you've given us an indication. Can we have up on screen, please, pages 18 of statement ending 250. And if it helps you, thank you. I hope you've got on screen, Ms Pritchard, the position as at March 2020. 74 trusts, 149 foundation trusts, 6,700 odd GP practices, and approximately 11,800 community pharmacies. Jump forward 2 years to March 2022, 69 trusts, 144 foundation trusts, nearly 6,500 GP practices, and a drop again of about 300 community pharmacies. Now, the trusts change sometimes their locations and what the geographical boundaries. I'm not interested in those, but the drop in GP practices, are you able to help whether that is related to the impact of the pandemic?
Actually, in both circumstances, it's generally a similar thing that's going on, which is that not that individual locations are changing, but that the governance around them is. So this is predominantly mergers that we're seeing happening here. So, for example, where I used to work, Guy's and St Thomas's was formed of two previous organisations, Guy's and St Thomas's, which came together to form one new organisation some years ago, and that has happened. That's happened quite a bit over the last few years.
So in relation to the differences between the figures in 63 and 64, one should not jump to the assumption that that is a pandemic-related reduction, but perhaps more a result of mergers of trusts, practices, and indeed pharmacies.
I think that's right. I mean, certainly we have seen now more at-scale GP practice provision as well. Though saying that, I think there is no doubt that some smaller organisations, and this applies to primary care as well, did struggle in the pandemic, and therefore moving towards larger scale structures may well have been something that was happened a bit more quickly because of those pressures.
Can I ask you about primary care? Because in your statement at your paragraph 249, you say that primary care has seen a gradual reduction in the number of full-time equivalent GPs per patient as part-time working and early retirements offset increased recruitment of young doctors into GP training. Demand has increased with numbers of registering in practices. So do I take it there that there has been a fall in GPs numbers?
So the overall number of GPs is now actually rising again, but the point is an important one, which is that the more experienced, often partners, as they are retiring, newer trained GPs are joining the workforce, but they're often joining in a way that is more, reflective of of personal circumstances, which means it's more part-time. At the same time, the needs of the population are rising and the number of the population is rising. So the numbers mean certainly that you would, as a kind of GP, be feeling a great deal of pressure on your work right now.
Can I ask you this? Just stand back for a moment and take the mergers out of it for 1 second. Has NHS England got any sense of the impact of the pandemic on numbers of staff who have burnt out, left through stress and the like? Are you able to just give us an overview at the outset of what kind of impact the pandemic has had on your staff availability?
Yes, we've got two things have happened that are really noticeable since the pandemic. One is actually we have a lot more staff than we had pre-pandemic, and that was partly because there was, I think, so much of that sense that NHS staff have of the vocation being about wanting to make a difference, that many staff who might have otherwise retired stayed on a bit, and there was a real surge in the number of people applying to become nurses, doctors, etc., which has begun to flow through to the workforce. So we have about 70,000 more staff now than we did. The big, however, is that we are, though, still running at a higher rate of sickness than we were pre-pandemic. So that it went up a lot during the pandemic, partly driven, of course, by COVID infection. It has come down since then, but it is still higher than it was. And the main sort of single reason people are off sick actually was pre-pandemic and still is now mental ill health, anxiety, depression, stress.
We're going to look at some of the figures a little later on in your evidence, but that's helpful as a sort of starting point, if I can put it like that. And that really brings me on to the resilience of the NHS pre-pandemic. And I think you have set out, if it helps you, Ms Pritchard, at paragraph 197 onwards, the definition in the EPRR framework of resilience. And it might be useful to put up on screen, please. It's at page 52, paragraphs 97 and 98. But there we can see reference to the 2015 EPRR framework, which defined resilience as, quote, the ability of the community, services, area or infrastructure to detect, prevent, and if necessary to withstand, handle and recover from disruptive challenges. And then a little more detail given to that in paragraph 198. Withstand, handle and recover requires a stable platform, ideally headroom, or the means to create headroom. And there can be no two ways about it, Ms Pritchard. Is this right, that entering into the pandemic, the NHS had historically low bed numbers, is that right?
Yes.
High bed occupancy levels, particularly when compared with other G7 and European countries. And was it your assessment that coming into 2020, therefore, there was little flexibility in the existing capacity to respond to a rapid and significant surge in demand?
Yes, that's right. And I know this inquiry in previous modules has very helpfully gone into this in some detail, but the NHS was running at a very high level of occupancy, so there were real pressures pre-pandemic. And I think certainly the challenge of not having that headroom, which is described in this section of my statement, meant that there were certain consequences to how we had to respond in a pandemic that did make it particularly challenging.
May I put it in this way, and please correct me if you think I'm wrong. Everyone had to surge during the pandemic, but it's a question of how much you had to serve. And as far as the NHS is concerned, because of those low numbers, it had to surge even greater.
Yes, and also how quickly you got into surge territory. Yeah. So I think the thing that perhaps other countries were able to do was to have a bit of a buffer before you had to enter that sort of extraordinary surge phase. We didn't. So that rapid adaptation of estate, of what staff were doing, etc., was necessary for the first step rather than, if you like, for the second step of response.
Now, we have, I think you've probably been told, looked a lot at critical care capacity, but I just would like to look at more general availability of beds. And 3 documents, please. Could we have on screen, please, INQ 113287 _ page 6. And Ms Pritchard, if you've got tabs, it's tab 3, but it might just be easier to use the screen. This is a Health Foundation document, and set out there was hospital admissions and available beds. Beds is represented by the blue line at the bottom. Beds have fallen by 5% over the 2010 onwards, coming up to the end of 2019. And we can see their admissions rising much more steeply. And if we go, please, to page 11, acute hospital beds in OECD countries, and we can see there that per 1,000, as at 2018, England had 2 per 1,000. And you can see the comparisons from Japan with 7.8 to the lowest there being Colombia at 1.6. And again, that's just hospital beds. And if we look at hospital bed occupancy on page 12, please, running at high occupancy there, 89.6% in England in 2018. Israel highest at 92.3%, and the United States the lowest there in 64.3%. So that's just, we'll look at critical care in particular, I suspect, but that gives us an overview now of critical care beds and indeed acute hospital beds. I suspect you would always want to have more beds and a lower rate of occupancy going into a pandemic. And that may be out with her ladyship's ability to make a recommendation. But can I ask you this? having entered it now in the position that we've just looked at, are we in any better position now in 2024 if there were a pandemic in the next month or two?
So I think it's worth saying that we are very much still in recovery. So in relation to that original definition of resilience, I think it's actually really important that it has the word recover, it has the phrase recover from disruptive challenges. So where we stand today, clearly, not only do we still, it's worth saying, obvious point really, but we still have COVID patients in hospitals now. We also have a very significant job of recovery to do, both to do with care that was disrupted during the pandemic, but actually recovery for our staff. So the point we've just made about sickness, for example. We also have a wider challenge across our nation because the health of the nation is poorer as a result of the pandemic. And we have new challenges like long COVID, which is really significant both for patients and a significant issue for staff. We have some things that I would say have put us in a stronger position if we had another pandemic. For example, we have a data infrastructure which is much more sophisticated now than it was back at the beginning of the pandemic. We have better, we talked about beds, but we have a lot more community infrastructure around things like remote services, virtual wards, things that, again, were developed at pace in the pandemic. But at the sort of core of your question, which I think is also about estate, do we have is the estate in a better place to withstand a pandemic? Clearly, the government made a commitment to increase capital expenditure with a 40 new hospitals programme that has begun, and very welcome additional funding for capital announced in the recent budget. But it will take some time for that to feed through into actually putting the sort of state of the NHS into the kind of place that you would want to be to see that headroom built in.
Well, that very neatly brings me on to two things I wanted to ask about, which was very briefly funding and then actually the estate itself. Can I start with funding, please? And I just wanted to look through you, if I may, at your paragraph 231, which shows where the money goes. That's the title of the figure, not a name that I've attributed to it. It's at page 64 of Miss Pritchard's statement. And if we just go on one page, there should be a table. There we are. This sets out where the money went as at, I think it was the 20th of September or thereabouts in 2020. The funding comes clearly, if we look, from the Department of Health, 87% of which goes to NHS England, and we can see 4.3% to public health, and 5.3% to NHS activity support. And then from there, that 87% gets spread out into a number of different services, bulk of it going to clinical commissioning groups, as they then were. Yeah. And we can see there 1% is to directly commissioned services, 4% to other primary care, and then various allocations to specialised services, general practice, community health, acute care, mental health. That's probably an oversimplification of the position, I don't doubt, but it's helpful for us to have a sort of structure in mind. But I think you say this in your statement, that in due course, when the pandemic struck, funding initially was not an issue because the NHS received the funding it needed at the start of the pandemic. Is that right?
Yes, that's right.
All right. And are you able to help? How much money was given to the NHS?
So I think we were initially allocated, actually it changed so fairly frequently over the course of the year, but the initial allocation was, I think, in the realm of about 19 billion in the end. Not all of that was actually needed or spent, but that's the point about the support was there had it been required.
So it's not a question that the decisions were made because there wasn't the money to enable anything to happen. There's a resource issue in terms of having the staff, having the beds, having the buildings to scale up, not necessarily a financial issue. I'm not trying to minimise it. All right. And was there any difference in the way you were able to operate during the pandemic, in the way that funding was given to you? Were you effectively given a blank cheque and said, spend it how you want?
No. What was agreed that was different was budgets that were based on, if you like, a much greater level of uncertainty about what would actually be required. But the process then of agreeing spend was, if you like, much more normal, and that was between NHS England, the Treasury, the Department of Health. So there was it was never anything like a blank cheque, but what there was the reassurance that if there were legitimate calls that met our delivery of government policy, then there would not be a financial constraint to being able to follow through on those.
Looking at the estate, and it's at your paragraph 251, you make the point that a well-maintained estate that is fit for purpose can improve the efficiency and capacity of a healthcare system. It probably speaks for itself, but you say that the maintenance backlog was growing year on year, and by 2019-2020, it stood at 9 billion, which was larger than the total capital budget. So can I just try and translate that into what it meant on the ground? Does it mean there were things that needed to be done to hospitals and the like that hadn't been done and were awaiting repairs, improvements and the like?
Yes, there's a process every year for organisations to assess their backlog maintenance, and it's categorised into kind of critical backlog maintenance and then less urgent. And what that would cover is everything from a known risk where there is, for example, we have some hospitals that still have rack concrete in them, so that would count as critical risk given the level of the well understood risk around rack concrete, through to much more important but less urgent repairs.
So do I take it from what you've said that there were, going into the pandemic, urgent repairs and then the various priorities, perhaps going down the scale of importance? And I think you set out at your paragraph 254, those 17,000 buildings, 12% of those predate the founding of the NHS in 1948, 17% is over 60 years old, and 44% is between 30 and 60 years old. So an aged estate on any view. You mentioned the plan for 40, I think it was 40 new hospitals the government announced. The aim was to deliver 6, was it by 2025? Do you know whether we are on track with that 6?
So I know you haven't quite asked me this question, but I will just get to your point about the new hospitals programme. But I think you've made a really important point about the age of the estate and the implications of that. So just worth saying, there are service interruptions every day because bits of the NHS estate fail. So, plant stops working, you have to close a theatre, you have to shut some beds. But there are also real efficiency issues when you're working in old estates. So that graph we looked at where it shows beds coming down, actually sometimes if you're able to work, for example, in which the new hospitals programme does, single rooms, that can allow you to have a lower length of stay appropriately because patients are getting the care they need in an appropriate modern environment with the right technology, etc., etc. And we know there's really good evidence around that. So actually, part of getting the estate right is partly to stop service interruptions, but partly to allow us to work really efficiently and be able to deliver safely some of the care required. Similarly, of course, it allows you to adapt to state much more easily. So with the new hospitals programme, it builds in all of those things to the specifications. And whilst a number of the schemes that were in flight have now been fully completed, others are still others are in flight. in practice, that programme has needed to be reprioritised a number of times. It's a government-led programme, but they have had to review it a number of times, partly to make sure it had fully reflected the urgency of dealing with the hospitals with the rack planks. And those are much bigger endeavours because in some cases they require a rebuild of an entire hospital rather than just parts of it.
Right. I wanted to ask you about the estate because actually one of the implications an ageing estate has on certainly this pandemic was the ability to properly implement infection prevention and control measures. And I suspect you wouldn't disagree that it's much harder to do in an estate where there is poor ventilation, large wards, no single rooms, no decent breakout rooms for the staff to change. It has implications across all of those things and not least of all patients who are 12 to a ward rather than a single or a double room. We'll perhaps look at some of the implications in a moment. Can I start then, please, with the pandemic in 2020 and a number of letters that were sent by NHS England, the first one being the effectively discharge letter, the stopping of elective care letter on the 17th of March, and perhaps if we call it up on screen. Thank you. INQ 87317. This is quite a long letter. I won't go through it all, but it is signed by you and Sir Simon Stevens, 17th of March, just before we went into lockdown, to all chief executives and everyone else listed there, effectively urging the recipients of the letter to free up the maximum possible inpatient and critical care capacity to prepare for the anticipated large numbers, support their staff. And if we just go over the page, I think there it is set out that the aim was to, to expand critical care capacity to the maximum and free up 30,000 or more of the NHS in England's 100,000 general and acute beds. Can I ask you this? What was the 30,000 based on? Was that some kind of modelling that was being done?
So there were two things happening here. There was the production of the reasonable worst case scenario modelling, and at this point also early data really from hospital admissions about what we were seeing happen in practice. And then there was, which is actually where this letter comes in, rapid work, but nonetheless sort of bottom-up work to work out what we thought the maximum operational possible was. So the reasonable worst-case scenario at this point was telling us, changed quite a lot over the days, and I know, again, the inquiries looked at this in some detail, but that we would have 400,000 patients requiring admission. Even at this point in the mitigated scenarios, it's still saying we could have, more patients in hospital than we had physical beds for. And again, within critical care, I think even our best case scenario at this point is about 11,000 patients who would need critical care capacity. So that far outweighed what would have been possible to do. But our view going into this was very much that it was absolutely imperative that we tried to do everything possible, not least because there were so many unknowns with the modelling. We were obviously all very hopeful that we would be wrong and it would be overstating just how difficult it was likely to be. And there were sort of non-pharmaceutical interventions being considered by government at this point as well. So this reflected, if you like, a bottom-up view that said what would be the maximum possible from the combination of things set out in this letter, which include, as you say, discharge, elective, working in partnership with the independent sector, etc., so that we could go in the best possible place to respond to the needs of patients.
And so to achieve that 30,000, there was the postponement of all non-urgent elective operations from the 15th of April. Why was it
So what the letter said was that people should, as it says on the sort of third line, had local discretion to wind down elective activity. And that was partly because at this point, there actually still weren't that many patients in hospital with COVID. So it was difficult judgment. All of this was dealing with lots of unknowns and uncertainty. But what we didn't want to do was oversteer in either direction and have patients who could have been treated not being, because we stood down too quickly. Equally, we certainly didn't want to be in a situation where we'd maintained non-urgent activity to the detriment of being able to treat COVID patients. And that was really the point about local discretion, because we could give a national direction, but it could only be interpreted in a sensible way by local leaders.
And that was hoped to free up between 12 and 15,000 hospital beds by that postponement of non-urgent elective. There was the urgent discharge of all hospital inpatients who are medically fit, which would potentially free up 15,000 acute beds currently occupied by patients awaiting discharge or with lengths of stay of over 21 days. And there was the use, in addition to that, of the independent hospitals. Can I ask you this? That 30,000 that was the aim to free it up, by when or over what time frame was it hoped that that 30,000 would be made available?
Well, I mean, again, sort of given where we were in the sort of reasonable worst case scenario and the way you could see the numbers going up, at that point, it was suggesting that there was likely to be a peak of demand somewhere around the middle of April. So we thought we had probably, a couple of weeks, ideally, to get this to be enacted in order to give the maximum chance to deal with what was coming. And under a level 4 EPR situation which we were in, this was a completely unprecedented set of things for us to be doing. Obviously followed government agreeing that package of policy measures of which these were part. But to send a letter like this saying we are now going to reshape the way the NHS works sort of within a matter of days would have only been possible in a level 4 situation. And it really did mean immediate action.
May I? Sorry.
In relation to discharging the medically fit, we're often told, as members of the public, we're often told that it's a continuing problem in the NHS, that you have people in hospital that are medically fit to be discharged but can't be for a wide variety of reasons. Why was this package or this policy going to work when obviously it's a problem you're confronting every day of your working life? So why was this going to work where it doesn't work in normal times?
Yes. So first of all, absolutely recognise the complexity of discharge, and that is an ongoing challenge for the NHS, for social care, for patients, for carers. But in this case, there were two important policy decisions that had been made to support discharge. One was to pause or suspend at that point continuing healthcare assessment, which is a process it's really a financial decision rather than a clinical decision, but can be one of the things that causes delay, because sometimes that process just delays people moving to the next stage of their care. But the other thing was the agreement, again, government agreement, to fund the first part of someone's post-acute care, sort of regardless of that assessment of eligibility, which allowed investment then to go to, a combination of colleagues in social care and others, to be, including NHS staff and local NHS community staff, to provide intermediate care, domiciliary care, care home places, in a model which we now refer to as discharge to assess, which means you're able to move somebody immediately out of the acute environment when they no longer need to be there, and undertake the appropriate rehabilitation and assessment when someone's in a place that's actually more likely to be suitable for their needs. So the speed of this was completely unprecedented. And again, lots of learning, I'm sure we'll talk about, related to that. But the actual model was based on what was already happening in some parts of the country and working very well. So the question was, with those two policy initiatives that were new and were accompanied by quite significant funding from government, would that allow everywhere to put those arrangements in place? I don't know, we might want to talk about impact in a moment, but in practice, there was variation in how quickly that was able to be done, largely based on where relationships were already strong and arrangements were already in place that followed that kind of model. But overall, we did see a very significant reduction in the length of stay for patients who were medically fit as a consequence of those two policy initiatives.
Well, I would like to ask you about the impact of the measures from the Phase 1 letter, because I think you set that out at your paragraph 558 onwards in your statement ending 251. And could we have up on screen, please, page 150 of 409251? And then I want to come back to one other aspect of the letter. But is this the position that NHS England did an initial assessment of the impact of that letter on patient flow over the course of wave 1 of the pandemic, conducted by the discharge cell towards the end of April 20, and it was presented to the NERV, was that the Incident Response Board? Analysis noted significant variation, which I think is the point you were just making. The data indicated an overall significant reduction in long stays in hospital since the introduction of the discharge requirements in 2020, and we can see set out there daily numbers of occupied beds for over 7 days dropped from 42,000 odd to just under 20,000. Those that were in hospital for 14 days dropped from 25,000 to 10,500. And all regions achieved significant reductions from between 62 and 72% in hospital long length of stays of over 21 days. And so, do I take it from that analysis about the length of time people were staying in hospital for? Certainly that did help to free up some of the beds that were needed for the influx of patients in later March and into April 2020.
Yes, absolutely. It's worth just, if you don't mind, just for 1 second, the reason length of stay is such an important way of looking at discharge is because every day there are new patients coming into hospital as well as patients going home. So it's a constant flow, as you say, of kind of coming in and going out. So actually, the length of time people are in hospital, you can sort of do the maths and convert that into beds, but it's not a static group of people who are in those beds every day. They change every day. So what we could see from this was that there had been a very swift impact of the measures. As you say, variation, significant variation, largely dependent on where those relationships were good and arrangements were, broadly speaking, in line with this model of working. But it is probably also worth saying that we saw, which wasn't predicted when we wrote the letter, a significant drop-off in the number of people coming to hospital. So the other factor that played into the availability of beds was the fact that, sort of, as I say, in an unplanned way, we'd seen such a reduction in people actually presenting through A&E and then going on to being admitted.
Can I just pick up on, are you saying there that in fact there was fewer people coming in? There was certainly fewer people coming into A&E than you had thought, and we've seen that borne out in various bits of data that we've already looked at. Can I just understand then, if we stand back, had this discharge policy not been brought in, what do you think the impact would have been on people seeking hospital care in the NHS in England? I mean, effectively, did it work?
Yeah, so the discharge policy, for the stated aims at the time, which was, back to, we thought we were going to have this extraordinary influx of patients for COVID who would need hospital care, therefore pulling every lever to try and, safely, as in the sort of based on existing best practice that we knew worked in other places, could we get to a place where people who really did not need to be in hospital anyway, so were delayed leaving, could get out in order to make space for people who we had anticipated would require inpatient care, then it certainly made a huge contribution. Again, one of the things we were aware at the time was lots of individuals and families didn't want to be in hospital because there was a understandable fear as well about being in a place where we were expecting an awful lot of people to arrive with this infection. So I think that difficult to quantify what the different elements of all of these things meant, also I should say difficult to disaggregate what those different elements meant in terms of the overall impact. But as I say, those two big policy changes, the funding that then supported that, particularly that sort of first period of care post the acute phase, did enable us to do something, my lady, as you say, that we haven't managed to do really before or in the same way since, which was to get to a place where those who were medically fit were able to leave hospital in a more timely way.
Let me ask you this. If there were similar predictions in the event of a future pandemic, would there still be the need now for there to be a discharge policy of sorts brought in to free up the kind of capacity in the tens of thousands that we are looking at in that letter?
Yeah, there is a piece of work that we did that evaluated later on, actually in 2021, the overall impact of what we were then calling the discharge to assess model. Yep. And what that suggested was that over the course of the programme, it had allowed us to release sort of well over 6,500 beds and actually 11,000 staff worth of time. So our sort of findings at the time on quality were also that, and again, I'm just to be clear, this was the latter part of the, this is nearly a year on from this time, but from a quality perspective, the feedback was that was actually leading to lower admission rates, though I don't know that we've readmission rates, sorry, though I haven't actually seen any really clear research evidence on that, but certainly from social care colleagues that it was also allowing patients to have an appropriate period of rehabilitation that meant that when they then went on for ongoing care, actually it could be well calibrated rather than on the basis of the acute phase where actually you don't get necessarily the best clinical assessment. So our view at the time was from a quality and from an impact on the NHS perspective and benefit for patients, the discharge to assess model seemed to be doing what we had hoped. And so it remains the core of our approach today. Obviously, the funding arrangements have changed, so it's a bit more now down to local systems to implement that in the way that they can within their existing envelopes and, of course, in partnership with social care.
All right. Can I just pause you there? You're obviously a signatory to the discharge letter, but were you personally involved in some of the detail of how many beds it was hoped to free up and how that was going to be achieved? Or was it done by those that work under you, as it were?
So my role at this time was to chair, you've already mentioned it, the National Incident Response Board, which comprised of all the, we call them cell leads, so the people who were running the national cells, of which there was one on discharge, as well as regional colleagues from government, colleagues from PHE. The focus being very much, just to be clear, on the operational response. So we weren't doing, as you say, the government business, which was much more of the complex work of cross-government coordination. This was very much looking into the NHS, but with a range of different, particularly clinical voices around the table to make sure that we were coordinating appropriately from a national, regional and local perspective. So the discharge cell were the people who were doing the detailed work on discharge, and as I say, it was led particularly in this case on discharge by the Department of Health and Social Care because of the social care element. So it was their lead, but our team working hand in hand.
All Can I go back to the letter and just ask about one matter, please? It was INQ 87317 and page 4 of that document. And paragraph 3B, please, Ms Pritchard. Clearly, back in middle of March 2020, there was limited testing capacity and it increased as the weeks and months wore on. But it says there, we are asking Public Health England, as a matter of urgency, to establish NHS targeted staff testing for symptomatic who would otherwise need to self-isolate for 7 days. And for those affected by PHE's 14-day household isolation policy, staff should be offered the alternative option of staying in an NHS reimbursed hotel accommodation. Do I take it from that obviously you want to just know if the staff member had COVID to send them home and keep them away from the hospital? If, however, they were isolating with someone in their house but did not have it, get them back to work? Was that the aim of this paragraph?
Yes, so the important bit of this, I think, is this line on an entirely voluntary basis. But we were hearing from staff, the way that again, sorry, just to take a tiny step back, but the way that the National Incident Response Board worked, the way that I worked was we were having literally multiple conversations a day with colleagues on the front line. So I had a WhatsApp group with every chief exec in the country. So we were in really regular direct dialogue with colleagues. And obviously, because I had literally only just stepped away from Guy's and St Thomas's a few months previously, I still was talking very regularly to colleagues across the NHS and previous colleagues. So one of the things we were hearing from staff, and again, some extraordinary stories. I know you've heard some very powerful testimony of this, of people who were saying, well, actually, I want to work.
Right.
And I want to make a contribution. And I don't want to have to isolate because somebody who lives in my house who may be COVID positive, I don't think I am. So we were very keen to find ways of supporting that.
Do you know, and if it maybe you can't tell me today, but do you know how many staff actually took up the option of staying in hotel accommodation during that first wave of the pandemic?
I don't have numbers, I'm afraid. I'm sure we can come back to the inquiry on that, though.
All right. Can I move on then to the second letter, phase 2 letter on the 29th of April, and it's behind your tab 6, and it's INQ 87412. Perhaps the eye of the storm has passed to some extent, but clearly we're not in the summer when things were opened up a little more. And this letter really urged the restarting of some non-urgent elective care. And you set out there on the first page some of the work that's been done, some of the achievements that have been experienced. But it's the urging at this stage, at the end of April, do you think perhaps asking chief executives of trusts and the like to restart some non-urgent elective care was too soon, given what they'd been through in the previous 6 weeks?
So I think at this point, the letter, in fact, I don't think I know, the letter is really focused in that. I mean, again, you're right to say it's a long letter and there's a lot in it, so it's probably actually bigger sections on COVID, staff support, etc., than there is on the stepping back up of non-COVID services. But the focus of this letter is actually on stepping up non-COVID urgent services. So there is a reference in it that says, if there is local capacity, it is absolutely appropriate to be thinking about those non-urgent services. But at this point, the feedback that we were getting, particularly from, we're looking at our own data, but from clinical colleagues, was that there had been more of an impact on, for example, cancer care than despite the best efforts of everybody locally.
Pause there, Ms. Bishop, I'll help you, and I'll put that bit of the letter up. It's on page 5 of this document, so we can see what you're referring to. And it's the paragraph that effectively begins with the underlining. We're asking all NHS local systems and organisations working with the regional colleagues fully to step up non-COVID-19 urgent services as soon as possible over the next 6 weeks. And then it goes on to ask them to make judgments whether they have further capacity for routine, non-urgent elective care. So I'm sorry to have interrupted you, but that's where the letter gets to in terms of its request of the trust and the clinical commissioning groups and the like. Why, from your perspective, were you asking the recipients of this letter to get on with this work now at the end of April 2020?
Yeah. So you're right. This letter was written a little earlier than we had anticipated, because in the letter of the 17th of March, we give an indication that we expect that first phase to last for longer. But at this point, two important things were happening. One is the data was showing really clearly that we were coming out of that peak. So we've gone, you put it up on the screen earlier on, but we've gone over the peak. We're coming back down the other side. There were 13,000 patients in hospital with COVID at this point. So that was important contextual information, which is very different to where we'd been with the 17th of March letter. The second thing, and I think, again, this was one of the things that felt important about doing this letter, is we were being asked to provide clear direction to the NHS from colleagues, as I say, through these sort of daily conversations, through the conversations that Professor Powers was having with Royal Colleges, from others, because we were in that level 4 environment. So it was important, I think, that we were able to respond to that. It wasn't out of the blue, this letter, it wasn't unexpected. We were working with colleagues in advance to say, this is now new circumstances, here's a new set of things that we're asking colleagues to do, which then allowed, through the EPR structures, people to kind of get on with at this point, sort of importantly different emphasis to their work.
The message, sorry to interrupt again, the message in the first letter was carry on urgent non-COVID services. Yet it seems as if that wasn't happening, if you had to tell people to step them up.
Yeah,
Why?
I think in practice it was harder for locals. So two, again, probably worth saying two things. One is an obvious point, and I know the inquiry's heard, again, really powerfully about this, but the level of uncertainty about what was happening in that first wave, and that sense of we're just pulling out all the stops, and colleagues locally just doing kind of everything they could to respond to the needs of patients, meant that with the best will in the world, some services like screening services, even though they weren't formally stood down, in practice, that just hadn't been able to be maintained. But the second thing is, and I know we'll talk more about it, but it was that need to redeploy staff in order to be able to meet the areas of greatest need, meant that some of the staff who would routinely have been doing, say, cancer clinics or cancer surgery, had been asked to do really important work to support intensive care and to support urgent emergency care flows. So this was not, I think, to be clear, because anyone had done anything wrong, quite the opposite, but it was really about reminding people that, okay, we are now coming down from that peak. It is time to look again at how staffing is working locally, how services are working locally, and make sure that those urgent services are fully restored.
That wasn't really the point of my question.
Sorry.
The point of my question, don't worry, I probably didn't make it sufficiently clear. The point of my question is, COVID is potentially lethal, cancer is potentially lethal, and you'd told people to carry on with cancer screening, amongst other urgent non-COVID conditions. So why were trusts not implementing that direction, and why were they moving people from cancer screening programmes or cancer clinics?
Yeah, sorry, my lady. I think it was just, it's trying to, I guess, stepping back, we do set direction, and in this case, in level 4, we were giving much clearer direction than we would normally would, and certainly than we would do now. But it was still very much up to local organisations then to interpret the information we were giving, the instruction we were giving, and work out how to do it locally and what they were and weren't able to do locally. Because you can set a framework nationally, but I know, as of many years of being working in a trust and being on the operational side, you can only do some of this when you know what staff you actually have, what your estate looks like, what the level of demand is in your place. So the way we work always has to be very much kind of with that understanding that we set a framework, but then we work really closely with local organisations, but who ultimately still have to take responsibility for the implementation locally and for interpretation locally. And in this case, I think what we were seeing, what we were hearing, was the level of pressure some organisations, not uniform, but the level of pressure some organisations were under. They had really struggled to maintain those non-urgent services because they didn't have the resilience, particularly in staffing, to be able to run multiple things at once, and they'd had to put all of their effort into responding to COVID. So even though this is only, as per your question, this is a little bit sooner than we had expected to do a second letter, it was really important for us to signal to everybody that it was now time to make sure that if they had to make those local decisions, they needed to go back and make sure that they had now sort of looked again at how staff were being deployed to make sure that those non-COVID urgent services were fully restored, as you say.
I think in the middle of your answer you said non-urgent, but you've just at the end said
non-COVID. Non-COVID urgent, yes, sorry.
Can I just pop back up on screen, please, page 5 of that letter, because it may make sense if one looks at the paragraph beginning, in addition, you should now work across local systems and with your regional teams to make the judgments on whether you have the further capacity for at least some routine. It was more, can I put it this way, aspirational than mandatory in its tone. If you can do it, please try and restart non-urgent elective care. Was that really the message you were trying to send out there, Ms Pritchard?
So the primary function of this letter was, as I say, was the sort of, we are now in the next phase. There are a range of things that will be distinctly different to what we were doing in phase 1. So particularly in relation to elective care, it was reminding everybody that it was hugely important to fully restore any services that had been disrupted that were urgent in nature. But on the non-urgent work, as you rightly say, this was permissive. Right. So there were some parts of the country that actually hadn't been terribly badly affected by COVID. So if I think about the Southwest, for example, in wave 1, so they were able to restore the non-urgent work actually more quickly than some of the parts of the country that had been very much more affected.
All right, well, can we look at the phase 3 letter? Because there's a slightly different language adopted in the phase 3 letter, which was issued on the 31st of July. And can I have up on screen, please, 51407? Thank you very much. And it's at your tabs 7, Miss Pritchard. But here we are now at the end of July. And the third phase letter obviously starts by thanking everyone, updates them on various COVID alert levels, the priorities, the financial arrangements. I don't want to get into that, but if we could go to page 2, NHS priorities from the following month, and one can see there at A, accelerating the return to near normal levels of non-COVID health services, making full use of the capacity available in the window opportunity between now and winter, and then preparing for winter demand pressures, and then dealing with lessons learned. Can I just ask you this? The winter demand pressures, was it envisaged we may have a flu pandemic then in winter 2020 into 2021? Or was it still worried that there might be a resurgence of COVID, as in fact happened?
I don't think you mean pandemic, do you? I think you said...
Did I say pandemic? I meant just a flu outbreak. Sorry, it's my fault. Yeah, was it envisaged that the preparation for winter demand pressures was just ordinary winter flu, for want of a better phrase, or was there still concern that there would be a resurgence of COVID-19?
Yeah, we were absolutely concerned that what we would have would be a combination of normal winter pressures and, as it says here, further probable COVID spikes locally and possibly nationally. So we were anticipating a potential second wave at this point at a time of year that would be more pressured anyway because of the normal winter pressures. So you're absolutely right. This letter is different in focus because this is really reflecting the fact that now, when this letter was written, we had 900 inpatients with COVID, so very different to the context that the second letter was written in. And we foresaw that we would have this, as it sort of phrases here, window of opportunity over the back end of the summer and into autumn before we hit that winter period with a potential further COVID wave.
Now, if we go, please, to page 3 of the letter, the accelerating the return of non-COVID health services included the restoration of the full operation of all cancer services, that work to be overseen. And if we could go to the bottom of that page as well, recovering the maximum elective activity possible between now and winter. And if we go to page 4, there was various targets set out that ought to be achieved in September, at least 80% of last year's activity for both overnight and outpatients. Then there was reference to 90% of last year's MRI and CT scans and 100% of last year's activity for first outpatient attendances and follow-up. So a much clearer steer to the recipients of the letter as to what was now expected. But I think you are aware, are you, Ms Pritchard, that certainly there has been some criticism of this letter. NHS Confederation described the letter as being extremely challenging, naive, unachievable, and ultimately demotivating, it coming on the back of an incredibly intense period of work by all of the NHS staff. Why was it felt that in July, NHS England could be so directive about how much resumption of work there could realistically be, given how, no doubt, absolutely exhausted everyone was, having been through wave 1?
So your point about the pressure staff are under is really important. However, I think it's worth saying that, sort of as again, it's an obvious point, but one that's probably worth making anyway, is that the NHS is fundamentally here for patients. So everything that was done by colleagues across the NHS in the pandemic was patient first, and people put themselves into the most extraordinary positions to do what they could. And at this point, we were hearing loud and clear, particularly from clinical colleagues across the NHS, that, and again, goes back to your definition right at the beginning of pandemic response, that the recovery phase was now critical because the potential impact from having had to pause non-urgent work was now becoming really problematic for patients, and that we were in danger of not doing enough to recover those incredibly important services for patients with detriment arising. So we were hearing loudly from the patient groups we were working with. We were hearing loudly from clinical groups we were working with. We were actually also hearing loudly from many leadership colleagues across the NHS that now was the time, and that they wanted to use the window of opportunity to make sure that we were doing what we needed to do for all of our patients, and that meant recovery. In practice, actually, there was a massive increase in non-urgent elective activity over this period. Didn't hit the targets that are described here, but if I just as a headline, elective day case went from sort of roughly 60% to 80% over that period. Similarly, CT scanning 80% to 100%. So actually, the NHS responded remarkably to the ask of it to recover services. But it's absolutely true that there was some local representation where we were hearing people expressing understandable concern, and the NHS Confederation, as one of the sort of trade bodies representing those voices, did their job, which was to represent that to us so that we could try and make sure that in planning for this letter, in which involved, I should say, sort of 7 road shows with leaders in the weeks running up to it. We had a working group of 20 or so folk also working in detail with us, as well as clinical groups, patient groups and others, that we did get that balance right, which was reflecting the extraordinary things that NHS staff had done over the previous months, but that absolute need to put patients first.
Right, can I pause there perhaps just before and ask you a couple of questions just before lunch, if I may, my lady? You've mentioned a number of times we were hearing, and you, in answer to that last question, you said there was patient groups, clinician groups. Were you yourself involved in hearing from any patient groups directly, or was that left to others in NHS England?
That's a very good question that I would need to just confirm absolutely which meetings I was personally in and where I was hearing it from those cell leads. But certainly through representatives like like Health Watch or the Patients Association. I was involved in some of those meetings. There were far more going on, though. I know that other colleagues like Dame Ruth May, Professor Steve Powers were leading and then reporting back in. One of the things I was personally doing was making sure, though, that I was having direct conversations with my NHS chief executive and other kind of leadership colleagues, so that we would pull all of those different sources of conversation together.
Well, that's what I wanted to ask you, just this before we perhaps break. I understand you can't be in every meeting and you have to rely on your colleagues to report back. You've told us about your liaison with the chief executives, but what about at ground level, Ms Pritchard? Did you yourself ever go to a hospital or engage with nurses and doctors working on the ground during the pandemic?
Yes, I mean, I was very fortunate, I suppose, still to have particularly relationships back with Guy's and St Thomas's that meant it was easy to pop in and speak to people who also knew me in a slightly different role. So I thought I certainly didn't feel, I think, under any compulsion to tell me anything other than the direct truth, because you can do that when you know someone well. But I visited every Nightingale. I did visits when it was appropriate and when I could. I think we did every region within those first few months. I'd have to check the exact dates, but certainly they were. And I still do visits every at least couple of weeks, because I find that to be a hugely valuable source of insight, because there is nothing that will compare with just standing in a place talking to colleagues who are living and breathing some of the very real, both pressures and constraints, but also solutions and ideas, to be able to feed back into any of the data or the other sort of aggregate conversations that are going on.
We may return to that topic a little later this afternoon. Would that be convenient, my lady?
Certainly. I shall return at 2:05. We will definitely complete your evidence today, Richard, I promise.
Thank you.
All rise.